Thank you. I enjoy speaking. If you have any questions, certainly we could talk about it at the break. These are my disclosures, none of which are relevant to this talk. So my objectives during this course is for you to be able to diagnose the common hepatic lesions based on their imaging findings. I want you to be able to differentiate the uncommon liver lesions that mimic common liver lesions, and I'm going to use a problem-based approach with some challenging cases as teaching points. As background, as we all know, there's a large number of focal hepatic lesions in adults that we see incidentally, but it's important as radiologists for us to be able to characterize these accurately. Many are benign, even in patients who have known malignancy, and I feel like the vast majority of them, we can certainly characterize them using CT and MR and avoid having to do a biopsy. MR in a lot of cases may have advantages in characterizing these lesions, especially if you look for the presence of fat or for other features. So let's start out with this case. Here's a lesion. This is a T1 weighted image, the T2 weighted image, the coronal image, early after gadolinium in the arterial phase, portal venous, and more delayed images. And the question is, what is the most likely diagnosis? And just think about this. Is it A, adenoma, B, FNH, C, hemangioma, D, hepatocellular carcinoma, or E, metastasis? And the answer is hemangioma. And why do I say that? Because the lesion's dark on T1, it's bright on T2. It doesn't look like your typical hemangioma, but actually for this size, it's typical, meaning these giant hemangiomas, what you end up seeing is this classic peripheral nodular enhancement with progressive filling in, and it wouldn't let or completely fill in, but that's okay. Just based on the imaging appearance, the low T1, high T2, and the central high signal intensity area, and that characteristic enhancement, we can call it a hemangioma. What are hemangiomas? Well, as we all know, they're the most common benign hepatic tumor. It's been reported as many as 4 to 8% in autopsy. And these are the ones that we need to be able to diagnose as radiologists. And I think MR can characterize the vast majority. In the old days, they used to always say, oh, these are the light bulb bright lesions. They're not always as high signal intensity as CSF, but they often should be bright. And just as important, or more important, you should see the characteristic enhancement, that peripheral nodular centripetal enhancement over time. And most importantly also is that it should stay hyperintense to the liver on the delayed images. So here's a CT exam, and with the CT, we should confidently be able to diagnose it. It has that peripheral cloud-like enhancement, the nodular enhancement, with filling in on delayed images. No further tests would be required. Another example, even when they're small, we can characterize them. Here's an example. It's dark on T1, it's bright on T2. Still has that peripheral nodular enhancement with complete filling in. Confidently, we should be able to call this a hemangioma. What are the atypical hemangiomas? Well, actually, in my opinion, these are typical based on their size. If you have the flash-filling hemangiomas, those are the ones that are relatively small. They have rapid complete enhancement on the arterial phase, and they're bright on T2, and they stay enhanced on delayed images. The giant hemangioma was the example that I showed. The actual size isn't important, but it's more the imaging features where it has a, quote, scar-like appearance, which is high signal intensity on T2, and it has that typical globular enhancement with lack of enhancement of the center. And the one that we struggle with, as we'll show you, is the sclerosing hemangiomas, because those don't have the characteristic appearance of a hemangioma, and they can be challenging. Again, here's a flash-filling hemangioma on CT. Hypodense on the non-contrast, completely fills in and remains enhanced. Similar to blood pool, if you look at the adjacent vessels, such as the hepatic veins, you could see, and portal veins, you could similar to blood pool. Another example on MR, certainly this one's bright, light bulb bright. But what's interesting here, and you see this on CT as well, is you get these transient signal intensity difference on MR, also referred to as THAT or transient hepatic attenuation difference on CT, and we see them quite frequently with hemangiomas. So this part actually often will make me look for the central area to see if there's a mass, and sure enough, you see the mass. In this case, as often the case, it's due to hemangioma. This was the index case. Again, this was that giant hemangioma that we talked about. Here's on CT, similar appearance where you see that globular peripheral nodular enhancement progressively fills in. It doesn't bother me, the fact that it doesn't completely fill in. And there's no point in getting extremely delayed images to see it filling in. This brings me to my favorite part, the mimickers or tricky cases. Question here, is this a 50-year-old male, left upper quadrant pain? We see this lesion. It's got some enhancement. It's peripheral. Question, is this hemangioma? Raise your hand. This is an HCC. Raise your hand. You're not voting. Raise your hand. Same story here, T1, T2, peripheral nodular enhancement. Again, same differential. Is this hemangioma? Is this HCC? Well, you might think it's hemangioma, but what happened here? This is the initial exam 3 months later. Clearly isn't a hemangioma. This was HCC. Although it doesn't have that classic arterial enhancement and washout. You might even think that could have been a cholangio, but I looked at the path and they said HCC. How about this one? Hemangioma, HCC. Not voting. This was a hemangioma. Now, why do I say that? Well, in this case, it's nice because we have images earlier. This is 3 years earlier. You can see that it's low signal intensity on T1, high signal on T2, peripheral nodular enhanced fills in, but more importantly, it hasn't changed in 3 years. So obviously, if it was an HCC, it would have grown. How about this one? Hemangioma, HCC. Arterial phase, venous phase, delayed phase, looks confusing. This is what I talked about before. This is the sclerosing hemangioma. The sclerosing hemangiomas can be difficult to diagnose because they lack that typical high signal intensity on T2 weighted images or the peripheral nodular enhancement. The advantage is sometimes if you have old films to show that it's stable, and sometimes you do have to biopsy these. Another example of a sclerosing hemangioma, T2, diffusion, it's bright on the ADC. There's some volume loss, there's some peripheral enhancement, but in this case, the question would be, is this a sclerosing hemangioma or is this a cholangio? And it'd be hard to tell the two apart, I think, on imaging sometimes. So this is one of my favorite slides. You'll see it on another one of my talks. You're confused, you're wondering which way you should go. Well, the way I take it is you should consider the general patient population. So in other words, hemangiomas have typical imaging features in the general patient population. However, I didn't give you the history, but you may have noticed that if you have a cirrhotic or a patient who has high risk of HCC, you got to think of HCC. And as Rich Barron, who unfortunately is no longer alive, he used to say that nothing likes to live in a cirrhotic liver, the exception being HCCs, dysplastic nodules, or regenerative nodules. Hemangiomas is less common, certainly not 5% of the population, and you should start to consider HCC or cholangio, and at a minimum, consider a short-term follow-up when the lesions are small. So again, in cirrhotics, hemangiomas may not be specific nor typical, and they can be difficult to diagnose. They decrease in size, they become more fibrotic, they lack that typical high signal intensity on T2 and enhancement patterns, and certainly, as I illustrated, it's helpful if you have old images because it'll show the more typical appearance of a hemangioma or the fact that you have stability. And again, sclerosing hemangiomas is a difficult diagnosis. You may need stability or you may even need to do a biopsy. How about this one? Is this a hemangioma? Certainly has the nodular peripheral enhancement. It looks somewhat heterogeneous. You might think there's a central scar. So what would you do next? Well, you should do an MR. And why do you want to do an MR? Well, here's an example. You can see it's low signal on T1, high signal on T2. You could say it has some peripheral nodular enhancement, but the advantage of MR is you have multiple phase imaging and different sequences. You can see that nodular enhancement is washed out. It's not filling in like a hemangioma should. This is actually a large HCC. I've seen these called by trainees atypical hemangiomas, and I like to say that they're atypical hemangiomas because they're not hemangiomas, so be careful. The other thing to realize is these giant masses, you don't have to have a history of cirrhosis. If I see a large mass, especially in an elderly patient, I often think of HCC as illustrated here. How about this one? This is a scary case. Obviously, if you've been doing this for a while, like I have, you start to see the scary cases. This is a 66-year-old, had a CT angiogram, had a nonspecific liver lesion, was read as a hemangioma most likely, recommended follow-up. Fortunately, they did end up not doing the follow-up. So what happened here? This is 3 years later. Clearly wasn't a hemangioma, right? It's got some volume loss. It's not bright on T2. It's enhancing. And this was a cholangio, unfortunately, and the patient ended up expiring. How about this one? Well, most days this would be a hemangioma, echogenic liver lesion. Did an MR, What does the MR show? Well, here's the in phase, the opposed phase. You can tell it's opposed phase because all the organs are etched in black. You can see signal loss from the presence of fat. It's not typical because it doesn't have that nodular enhancement. Again, it's not bright like as it should be. It's more similar to spleen, which is always of concern. So this, again, wasn't typical for hemangioma. The presence of fat, which is your friend, helps you make the diagnosis, and this is an HCC. So again, fat is important. It limits your differential. In my opinion, it limits it mainly to HCC versus adenoma, depending on the patient population. Certainly, you can have angiomyolipomas or lipomas, but that's often macroscopic fat. It's been said that FNHs can have fat, and that's true, but in my experience, usually the rest of the liver often has fat. So again, upon further questioning, that's when you use your demographics. This patient had a history of hepatitis and risk factors for HCC, so you have to start considering HCC. How about this one? You just see peripheral nodular enhancement, the arterial phase. The advantage of this is that you have multiple sequences. On the multiple sequences, what do we see? That nodular enhancement, again, is washing out. And now we're starting to see capsular enhancement. So whenever you see capsular enhancement like this and washing out, and again, it's not as bright as you would like to see for hemangioma, this, again, was an HCC. How about this one? Nice CT scan showing the enhancement similar to the vessels, but what's unique about this example, as opposed to that peripheral nodular enhancement, what are we seeing? We're seeing a continuous rim of enhancement. So whenever you see a continuous rim of enhancement, you have to start thinking of other things. This is ring enhancement due to breast cancer metastases. This brings me to my next section. So what's the most likely diagnosis here? We have a liver lesion here. It's got a central scar, as you can see. Your choices are A, adenoma, B, FNH, C, hemangioma, HCC, or metastases. This was focal nodular hyperplasia. So this is another diagnosis that you should be able to make, not require a biopsy. So what do we see? We see the lesion is often referred to as a stealth lesion. It's similar to the rest of the liver, but more importantly, it has a central scar, and the central scar shows delayed enhancement. Scar is also bright on T2, which helps in the diagnosis, although, as we'll talk about, that's not definitive. So these are the second most common benign hepatic tumor. They're generally seen in middle-aged females. They're generally asymptomatic. They don't bleed, and they're not malignant, but you want to distinguish these from adenomas and other lesions. And again, if you look at the pathology, and as mentioned before, it's important to work with your pathologist, and you realize what you're seeing on imaging is similar to pathology. These are homogeneous, as I mentioned. They tend to be hypervascular. They tend to be lobulated. They have a central scar that's low on T1, high on T2, and shows delayed enhancement. If it's classic, we don't need to do any further workup. We don't need to do EOVIST. Another example, CT scan, similar appearance, has a central scar, a homogeneous lobulated lesion. Again, this was FNH. And then, as I alluded to, you can use gadoxetate, also referred to as EOVIST or Primavist in Europe. And what does that help us in? It shows retention of the contrast, although now we're seeing retention of the contrast can be seen in adenomas as well. But the key feature is that if you see a central scar with retention, you can confidently call it FNH, in my opinion. This brings me to my mimickers again. So the question here, is this an FNH? Certainly has a central scar, but what's different about this particular case? As we talked about before, the lesion is bright on T2, has that peripheral nodular enhancement, the center doesn't fill in, so this in fact is a giant hemangioma. What about this one? Does this look like FNH? Well, if you just rely on the central scar, you'd think it's FNH, but it's multiple. But what's different about this case? It has not homogeneous arterial enhancement, right? So you want to see homogeneous arterial enhancement, and on delayed images, you want to see the central scar enhancing. So at this point, we know it's not FNH, or it's not typical for FNH. And this patient, I didn't tell you the history, but the person, in fact, had colon cancer, and these are metastases from colon cancer. How about this one? This is a 34-year-old female, abdominal pain, a relatively large lesion, has a calcification, it enhances. Most of the time this would be FNH, but since I'm showing it in this lecture, I'm showing you some of the mimickers. What's different about this case? Well, it's an older case, but it doesn't have that homogeneous enhancement. On boards, this would be an FNH. Why would that be? Because when you're studying for boards, they say what happens when you see a lesion that's low signal on T1, central scar, bright on T2, and fills in. It's going to be an FNH. But what's different about this case and what worried us at the time was, again, it didn't have that homogeneous arterial enhancement. Admittedly, this is more delayed, but it looks somewhat heterogeneous. At the time, we did a sulfur colloid, which we don't do all the time, but you can clearly see it's not taking up the agent, as you might expect it to with FNH, although not all FNHs take it up. And this was biopsied, and this is fibrolamellar HCC. This is an uncommon variant of HCC. It's the same patient population, unfortunately, as FNH. It's younger patients and middle-aged females, as well as males without cirrhosis. They say the prognosis is better than HCC, but it's still not very good. But I don't want you to start calling all cases fibrolamellar. What you need to realize is that fibrolamellar is exceptionally rare. We see a handful of cases at Northwestern, and we're a transplant center. They're mainly referred. In contrast, FNH is very common. I see it on a daily or weekly basis, and I made this up, but I think it's even greater than 1,000 to 1. I mean, I've probably seen, maybe a dozen of these in my career. How do you distinguish them? Well, generally, fibrolamellars are larger, although there can be overlap. The central scar, as we talked about, typically is hypointense on T2, but not always, as I showed you. But in my opinion, the best clues are that if you start to see a heterogeneous lesion, you see heterogeneous enhancement, as opposed to the FNH that look pretty classic and homogeneously enhancing, then it's going to be an FNH. But if you start to see worrisome features, if FNH has atypical features, then you need to consider either close follow-up or a biopsy to exclude fibrolamellar. And this is fairly uncommon, obviously. How about this example? This is a 35-year-old female, incidental liver lesion. It's echogenic, hard to tell. So we recommended doing an MR. And why do we recommend doing an MR? You can see the lesion here, the opposed phase. Again, you can tell it's opposed phase because it's etched in black. You can see signal loss. So what does that suggest to us? That there's fat. And fat, again, is your friend. It's not bright on T2, so it narrows our differential. Going back to the list I gave you before, it's either adenoma, HCC, or rarer lesions. This being a younger female, we think it's going to be an adenoma, which it certainly is characteristic of. These hepatocellular adenomas we see on a regular basis as well. It was rare prior to widespread use of oral contraceptives. It's much less common than hemangiomas or FNHs. You have to think about them when you have glycogen storage disease, anabolic steroids, and generally they're surgically resected when they're large, because those are the ones that are at risk of malignant degeneration, especially the beta-catenin mutated subtype. On CT, they can be like this, where it's somewhat nonspecific in comparison to meningioma, where it's nodular enhancing. You can see the presence of hemorrhage in the setting of an inflammatory subtype, and fat if it's a HF1 alpha mutated subtype. MR is more sensitive and specific because it can often show you fat better than it can on CT, about 1/3 to 3/4 as opposed to 7%. And again, it doesn't have the imaging features of hemangioma. Blood, too, limits your differential. Here we have a liver lesion with hemorrhage. It's a young female, 33, so again, similar differential, but a little bit different. In this case, it's either adenoma, as we mentioned before, it could be HCC in the setting of the right demographics, metastatic disease, hemorrhage into cysts, and only rarely, in my experience, do hemangiomas or FNHs haven't seen those bleeding. So this, again, was an adenoma. This was embolized. This, in contrast, was another patient presented through the ER, liver lesion that bled. Difference is the demographics, 58-year-old Chinese male. So this turned out to be, as expected, HCC. How about this one? Well, here's a 41-year-old male, abdominal pain, elevated LFTs. They end up doing a biopsy, and it showed adenoma, but it looks somewhat heterogeneous, and based on its size and appearance and it being a male, it was resected, and this, in fact, was an HCC that developed in an adenoma. And that's the reason that we have to think of HCC developing in adenomas, especially in different subtype, if it's in males, and it looks somewhat heterogeneous. So HCC developing from adenomas, more commonly seen in what's referred to as the beta-catenin activated subtype, when it's larger, when it's a male, when it's anabolic steroids, so maybe we'll start to see it in the baseball players, or are seeing it in baseball players, glycogen storage disease, and postmenopausal women. Let's talk about hepatobiliary agents. There's certainly advantages of hepatobiliary agents. We use it selectively, not in all patients, but it has the advantage of having a hepatocyte phase and biliary excretion. We use it for problem solving. There's two types. Certainly there's GAD-oxetate disodium, also referred to as Eovist, where you get delayed images at 20 minutes. And there's also GAD-BAPTA or Multihance. We don't routinely use this. We used to use it, but you need to wait an hour to 3 hours, which obviously is not ideal. So during the hepatocyte phase, lesions with minimal or no hepatocytes won't accumulate it, and those with functioning hepatocytes, FNH, and some well-differentiated HCCs will accumulate it. Some people refer to the hepatocyte as do I, as the hepatobiliary phase, and these are going to be bright on the delayed images. In contrast, adenomas generally are dark, unlike FNH. So let's look at an example. This is FNH, as I showed you before. There's a central scar on T2, homogeneous arterial enhancing, and retains the contrast. And what's interesting about these, you're not used to seeing it, but the FNH central scar looks much bigger on the hepatobiliary phase, delayed imaging. How about this one? Well, here we could see there's a lesion in phase here, opposed phase here. So given that it's losing signal, we know it has fat. So we have a good idea and would think that it's going to be an adenoma. But sometimes you're a lot more confident when you, in fact, have the Eovist, because on the Eovist, you can see on the more delayed images, there's a lack of retention of the contrast, especially on the 20-minute delayed images. And you could tell it's you're getting the hepatobiliary phase because you're starting to see the bile duct fill with contrast. Another example, this is a nice use of Eovist. You can see there's a pedunculated lesion coming off the liver. A lot of these turn out to be as suspected adenomas, but certainly on the CT it looks nonspecific. Even on the conventional MR, in this case it looked nonspecific because it wasn't losing signal on the opposed phase images, but it did not have a central scar. And the fact that it didn't retain the contrast on the 20-minute delayed images made us pretty confident in the right demographics. This is going to be an adenoma, which it was. How about this one? Well, this is a little bit of a scary case. This is a 73-year-old male. Elevated LFTs was done at our VA. Single-phase study showed a lesion with a central scar. Triphasic study really didn't help. It showed that central scar. You might think it's an FNH. Unfortunately, here's the MR, you can see again the in-phase, opposed phase, T2. And then on the Eovist or the GAD-oxetate, you can see there's lack of retention. So what happened here, the patient ended up having a biopsy and even a resection, and the pathologist read it as an adenoma. So that's unusual, given that's an older male. And unfortunately, this is 3 years later. So it shows you that as radiologists, you should trust your gut. You can't always trust biopsy. Apparently, sometimes for pathologists, it's hard to tell adenomas from HCCs. When I used to show this in a talk, somebody used to say, you should get another pathologist, which is certainly true, to re-review it if it doesn't follow what you're thinking. Because in this case, now we start to see the presence of fat-containing lesions, and it's an HCC, it's hypervascular enhancing. Here's another example. This is an important entity we've become more and more aware of, and I showed this at RSNA, and a bunch of my friends within a few weeks weren't aware of it, but once they saw this, they started calling it, and I think the same thing was true with us. This is a patient with colon cancer. He had Lynch syndrome, developed some new liver lesions. We did the Eovist, and why am I showing you that? Well, you can see the lesions are arterially enhancing. And what's interesting on the delayed images, what do we see? We see that central scar. We see retention of contrast material. So the question is, are these METs? Well, if it was colon cancer, usually colon cancer is hypovascular. Usually it doesn't retain the contrast. So the question is, I should have asked you the question first. Is this METs, epithelioid hemangioma, or FNH-like lesion? And the answer is FNH-like lesion. So what are these? These are axilloplantar-associated FNH-like lesions. So as a radiologist, you could be the first one to suggest the diagnosis because they obviously don't come in with that diagnosis. These are lesions that mimic metastases. They're seen in about 22% of patients treated with axilloplatin, which is used for colorectal and pancreatic cancer, so a large percentage of our patients. It usually occurs 3 to 4 years after completion of the axilloplatin. The interval for the development of hepatic metastases obviously is much shorter. It's believed secondary to oxaliplatin-induced sinusoidal obstruction syndrome and local disturbance in hepatic perfusion. These are FNH-like lesions. They tend to be hypervascular. As I mentioned, they retain the contrast. You want to look for that central scar. While liver mets from, as I mentioned, GI adenocarcinomas tend to be hypoenhancing, don't retain the contrast, and generally, unlike the other example that I showed you, they don't tend to have a central scar. So in conclusion, CT and MR are, as I showed you, highly sensitive and specific for hepatic lesions. I think MR often offers greater specificity over CT in characterization, although generally we can make the diagnosis with CT. Certainly the most common liver lesions can be identified and characterized. Certainly, as I mentioned, the hemangiomas, including the different subtypes, the FNHs with scar and typical enhancement characteristics, the metastases. If you have an abdominal pain and you have a lesion that either bled or has fat, as we talked about in a young female on birth control pills, you should think of adenoma. In contrast, if you have a hemorrhagic lesion in an older patient or a lesion that has fat and is not on birth control pills, certainly think of HCC. If you have FNH-like lesions, you need to consider and look back at the history, and because it's often not provided, as the patient had oxaliplatin chemotherapy, and these should be distinguished from malignancy. And as a radiologist, you can make a huge difference, obviously, in the diagnosis. And this is my email. If anyone has any questions that they want to, outside of talking to me, let me know. Thank you.